Okay. Okay, so we are now live. Oh, and here Spiro is joining us as well. Hi, everyone. It's good to see you, well, virtually. We are excited to have another one of these Ask the Hematologist events where we're able to get some miscellaneous questions and get some info to you that you have been asking for. We have 3 hematologists joining us tonight. If you would like to go ahead and introduce yourselves, everybody, whatever order you'd like.
Yeah.
Shruti, why don't you go first?
All right, so I'll go first. So I'm Shruti Chaturvedi. I'm one of the non-malignant hematologists at Johns Hopkins in Baltimore, and I focus on TTP along with other disorders that look very much like TTP. Very happy to be here.
I'm Radhika Gangaraju. I'm the hematologist at University of Alabama at Birmingham in Alabama. And similar to Shruti, my focus is on TTP and other blood clotting disorders. I'm Radhika Gangaraju. I'm the hematologist.
And Spiro, you're muted. You might need to unmute yourself.
I got all kinds of problems. Sorry, I'm the one that was late. I'm Spiro Cataland. I'm a hematologist at Ohio State University with an interest in taking care of patients with TTP, as well as research, as well as some other related disorders we call TMAs.
So one of the first things I wanted to have you guys kick off talking about is a very hot topic. It is the COVID-19 vaccine and whether it is a good idea for TTP patients to receive it. So who wants to talk first?
Sure, go ahead, you take that one.
Sure. So for all of my patients with TTP, I'm recommending that if they are able to get access to the vaccine, then they should be vaccinated. The truth is that the chance of getting COVID or having a poor outcome from COVID is probably higher than that of having a significant reaction from the vaccine. I know that there has been some concern about low platelets after getting the vaccine based on some news reports of people developing a disorder called ITP or immune thrombocytopenia after getting the COVID vaccine. As of this point of time, we do not know of any reports of people getting TTP after the vaccine. Hypothetically, there could be a concern of someone who is already primed to get a relapse, who has very low ADAMTS13 perhaps being triggered. But for most of my patients, they're already getting ADAMTS13 monitoring, and I'm not telling them to hold off. For people that are getting rituximab a lot, there is some concern that perhaps their response to the vaccine may not be as good as other people. That's because rituximab impairs the ability of your body to make antibodies. That said, even then, it is probably better to get the vaccine than not get the vaccine. I don't know if any of my colleagues have a different take on it or whether they have a favorite vaccine. I've just been saying get the one you can get your hands on because it's so hard to get an appointment.
Yeah, I agree with Dr. Chaturvedi that I don't think there is any contraindication for being vaccinated just because of having a history of TTP. And I guess that would be one of the reasons to be vaccinated, to prevent all the long-term complications that are probably more common in people who have autoimmune diseases and other comorbidities. And I have not come across any triggered episodes of TTP just from the vaccination itself. But I mean, there is always a concern that whenever someone is vaccinated, and especially when it happens on a large scale, we're going to see some side effects. And we have to take it with some discretion because people do get diseases. And compared to the normal prevalence or incidence of these diseases like ITP, people who are vaccinated are not any, I guess like the rates of getting these disorders is not any higher compared to the general population. So I don't think at this point we have any evidence to suggest that we should avoid vaccinations in TTP patients.
I agree. There's a theoretical concern with any autoimmune disease that a vaccine that activates your immune system might activate your fill in the blank TTP, ITP, rheumatoid arthritis. It's really more of a theoretical concern. It's not a real significant issue. I don't think anybody's have seen this. And I think that what I tell patients is, some people have said, oh, the studies were done too quickly. I don't trust them. They really weren't done quickly. They were done efficiently. And I think we're close to 80 million, if not more, people have gotten this vaccine in the last 3 to 4 months. And we're just not hearing a lot of issues with it. So there are patients, as Shruti said, that might not respond as well to it if you're on steroids or rituximab, but they should even still get it. Really, I've not told anybody not to get it. The main reason not to get it is if you've had an allergic reaction to other vaccines. Other than that, you really should get it. It's a pretty easy answer, I think.
And I think in terms of concerns about any kind of immunosuppressive therapy or rituximab for people who are being treated for TTP, I think we do have some guidance from societies about the timing of the vaccine. Again, this is all based on expert opinion, and we don't have any good, compared control trials or any of those studies informing the evidence here. But there are protocols being developed where people are asked to wait for a few weeks. So for example, if you are, waiting to start Rituxan, and if there is no urgency to start Rituxan, I think there is some consensus on probably getting the vaccine first and then waiting for 4 weeks after you get vaccinated to get your first dose of rituximab. And for someone who is on rituximab therapy already, and if you have not been vaccinated in the past, some of the institutions have developed protocols where the vaccine is recommended about 3 months after the last dose of rituximab. And that's only in situations where there is a possibility to wait to start rituximab. If there is urgency to start Rituxan in terms of your, how severe the TTP episode is, and if there is any urgency to start rituximab, I think you should go ahead and start Rituxan and then worry about vaccine, after the Rituxan doses are completed.
Did we cover that well enough, Claire? Anything we missed?
Yeah, so just if you want to speak a little bit more to the concerns a lot of patients have about getting Rituxan and the vaccine. So would you guys, I know we just went over that the timing needs to be correct. Would a patient who has had Rituxan, would the vaccine not work for them? Is there diminished evidence of diminished efficacy in your eyes or in your experience with vaccines after Rituxan, or how are you guys handling that with your patients in that sense?
So, I think theoretically we know that someone who's gotten Rituxan, like I said before, is not going to make antibodies as well as somebody who has not gotten Rituxan, say in the past 6 months or so. And it is too early for us to say whether people who've gotten Rituxan and then gotten the vaccine have an impaired response. It just hasn't been studied, although it's very likely. That said, it is not a reason not to get the vaccine because, for example, I'm making up these numbers here. If getting the vaccine in a person who is not immunocompromised or has not had Rituxan gives you 90% protection, and after Rituxan, you only get half of that protection. That half is better than nothing at all. And the consequences of COVID are still likely to be worse. We don't expect combining the vaccines with drugs like rituximab to have any added side effects, if that's a concern. We don't expect you to do poorly because you've had Rituxan with the vaccine.
And there are studies going on in assessing how the antibody response is going to be. I don't think it will be done specifically in TTP population. It's probably going to be done in people who have rheumatologic diseases or chronic neurologic problems, where they are taking plasma samples from these patients and studying how well they make these antibodies, or if there is any benefit of, plasma in these patient populations. But I don't think it will be done specifically for TTP patients to answer that question.
Yeah, I think the bottom line is the risk of COVID is much greater than the risk from the vaccine. And even if you might not respond, if you already got rituximab, it's still not a reason, as Dr. Chaturvedi said. You really have to try to protect yourself. Maybe you get revaccinated in 6 months. Maybe we all get revaccinated in 6 months, but you really should still do it. It's kind of an easy answer. Give it a shot.
Okay, good. And that kind of leads us into the world of Rituxan. So we have a patient that writes in stating, well, her daughter relapses almost every year. She had her last round of Rituxan in January of this year, and her ADAMTS13 didn't go up very high afterwards. It's not specified how high it did go, but it's already starting to decline back down. And her hematologist is reluctant to repeat Rituxan because it says repeated use will make it less effective. What would you guys recommend for somebody who Rituxan isn't working for as well? Is there a certain demographic that doesn't, Rituxan isn't found to work as well in? And what other options would you express for this patient for them to be able to stay in remission?
I guess the one thing I would ask is we have to understand what doesn't work means. And if you think about why we give rituximab, we give the rituximab to decrease the B cells that are making these antibodies. So if we're talking about someone who's relapsing every year, what needs to be discussed with the physician is it because the ADAMTS13 activity improves and then antibodies recur within that year, then there's a relapse, or did they not respond at all to the rituximab, meaning the ADAMTS activity never improved, which is kind of how we can now best judge if rituximab is working. So that's, I think, the discussion that needs to be had with her doctor. If it's not improving the ADAMTS13 activity and she's had a lot of relapses, you might need to talk about other immune suppressive treatments.
Okay. What other immunosuppressive treatments have you utilized with your patients that are common relapsers or have relapsed multiple times and aren't responding to Rituxan?
I have used cyclophosphamide, bortezomib, and I guess like when we go into these agents, we know that the response rates are not too great, but I guess like any of the immunosuppressive agents are probably equally efficacious. There are studies on cyclosporin, but I think I have had success with cyclophosphamide and bortezomib, and splenectomy seems to be another option as well, depending on how old the patient is, as well as comorbidities and those kind of conditions.
And I think one of the discussions that needs to be had with the doctor and the patient is, what are we trying to achieve with this treatment? There are some individuals, it sounds like this lady's daughter is one of them, who has already demonstrated that when their ADAMTS13 goes down, they relapse every year. So that's perhaps a stronger case to try other immunosuppression. And in addition to what's been mentioned, other drugs such as Imuran and Cellcept have also been used. It really is dealer's choice. You select the one for which the side effect profile is acceptable and give it a try. Many of these are well tolerated. There are other patients in whom we're really only treating the ADAMTS13 number and trying to get it up. And that is a more involved discussion about, do you really want to try more treatments potentially with other side effects to just treat the number if someone doesn't actually have a history of relapsing? It's more like an insurance policy, but that's a discussion to have with the doctor. For individuals that have had frequent relapses and other immunosuppression is not working, by other immunosuppression, I mean pills essentially. I agree with Dr. Gangaraju that a cyclophosphamide tends to work well, and if all else fails, taking the spleen out may be effective and nothing else has worked. And that certainly worked for some of my patients who've had the annual relapses.
It's once you get past the rituximab not working part, it gets to be a more complicated discussion with the patient's history of relapses as well as the different agents. And I'm sure her doctor is very good, but some doctors just don't see a lot of TTP. So I would really, it's a bit self-serving to say, look at our consortium website and find one of our physicians that might be nearby you and try to get in to see them, or even see if telehealth visits are possible, because that may help inform the decision.
And I hate to loop back to rituximab, but I think it's worth mentioning that what Spiro said earlier about what really does not work mean is very important. Because if the not work means that nothing happens after getting Rituxan, then you truly have a rituximab failure. But if you get ADAMTS13 numbers that improve, even if it's improving from 10 to 30, that might keep someone out of a relapse. And if they're dropping down sooner, maybe the easiest answer here is to treat more frequently, because of all of these treatments, rituximab has perhaps the least severe side effect profile and the most demonstrative effectiveness in TTP. So we also have patients for whom it seems like Rituxan doesn't work as well as it used to and wears off sooner. And many of them will just get a single dose every 3 months and stay out of trouble in terms of relapses. It may still be easier than trying to change your drug.
All right, kind of pivoting to a new exciting treatment that I know everybody is looking forward to. Do you have any updates or any comments on the recombinant ADAMTS-TS13 trials that are going on? First, we might want to give a little bit of a background of what recombinant ADAMTS-TS13 is and how it would benefit versus the other medications that are being used for TTP.
Perhaps that Spiro take this, he might have more experience with something like this.
With the trial, yeah.
Yeah.
No, I'm happy. So it's certainly under study right now. There's clinical trials going on around the world, and we've treated 2 patients at Ohio State with it. It's kind of being used in the study in addition to the standard treatment. So with steroids, with rituximab, if the physician wants to give that, and obviously with plasma exchange. So it's encouraging, it's interesting. It's hard to say too much more until we get the data from the study. But I think it's very reasonable. There's data from mouse models that suggest it can work very well. We've got to see if that holds up in the clinical trials. But it's certainly an interesting question. It's being used both in the acquired form of the disease, the immune-mediated, but also the congenital. But it's nice to see a lot of extra attention coming to the disease and treatments for it, and there's more and more than I think the general public has heard about still coming to the clinic. So that's encouraging.
There was also a question that was submitted about there is mRNA technology used to develop a vaccine for MS, which instructs the immune system of the MS sufferers not to attack the proteins that lead to the sheath deterioration that is found in the disease process. Would, in your guys' opinion, this be a technology that could eventually be utilized to help TTP patients so that the immune system would not then attack the ADAMTS-TS13 protease, or wouldn't generate the antibody that attacks the ADAMTS-TS13?
I'm not aware of any of these technologies being used for TTP patients. So maybe sometime in the near future, I guess, like with the vaccines, I think people are all aware of this mRNA technology. So maybe it'll gain more popularity in future.
Yeah.
Yeah, I would say I can't say too much more, but there are a lot of interesting things going on with new ways to treat and target the disease that are sort of in early studies. And the reason I can't say more, because all of us on this call will work with investigators and companies that are studying these things. We're just not able to talk about it because of confidentiality reasons. But I think one thing to say, something like, if you think about the mRNA technology, it's great for vaccines. It seems to be a great vaccine tool, but it's a short-term thing. So patients get this mRNA, it produces the protein for a short period of time, and they can generate antibodies against that. Any sort of treatment has to be a more sustained effect, most likely. But it's a good question. What you're seeing in these new technologies are being applied to TTP in different ways. And it's fascinating. It's interesting how these technologies all get applied to different diseases, and especially something like TTP.
I think, because TTP is rare, a lot of these studies will happen in other immune disorders first. I know this was still a mouse study in MS, but it is certainly plausible that things that come to fruition in other autoimmune disorders will eventually find their way to more rare conditions like TTP.
It's a bit easier, just to educate people, it's a bit easier for drugs to get approved in a rare disease, any rare disease, including TTP. So you can also see companies study things in a rare disease that they want to apply to a more common disease. And what happens in TTP, these blood clots in the very smallest vessels, occurs for different reasons in other patients. So people with diabetes or heart disease or strokes. So you see things kind of going both ways, from the rare disease to the more common one, and vice versa. It explains why companies are also very interested in studying TTP, because it might apply to more common things as well.
And that was another question we had received, is why are companies all of a sudden interested in treating TTP? And it has to do with the new technologies you guys are saying and the development that you're able to extrapolate some of the data into more popular diseases as well.
The sort of the regulations are easier, not easier. They're shorter term, smaller numbers for rare diseases. So relatively speaking, it's easier for a drug to be approved in something like TTP or ITP compared to something like heart disease or hypertension. It's not easy. It's also got the challenges of doing research in a rare disease. But the orphan drug laws have encouraged, and this is what it was supposed to do, encourage research in rare diseases that don't have a big market. So in that way, it's working quite well.
So another popular topic is what puts one patient at higher risk of relapse than others. So is it further away from a TTP episode that you get, the less likely you are to have a second one? Are there certain demographics? There's a patient that wrote in that they have systemic lupus and ITP for over 30 years, and they also were diagnosed with refractory TTP. Does that put them at higher risk? So if you guys would like to discuss what exactly that would look like.
You
guys go ahead and go. I'm talking too much.
Radhika, you want to check it?
Yeah, so I guess like there are multiple components for the question. In terms of relapse, I don't think we have a valid biomarker that predicts relapse. I mean, there are studies which show that people who have a persistently low ADAMTS13, when they are in remission, they are at increased risk of relapse. And in terms of, I guess, like routinely available other biomarkers, like there are studies still going on, but I don't think they are done on a routinely available basis. They are still in the research setting. So we don't usually do those labs for people when we see them in clinic, other than ADAMTS13 and like the activity of the ADAMTS13 and the inhibitor level. Those are the only two markers that we monitor right now that can sometimes predict. And there are also studies which show that for people who are admitted with an acute episode of TTP, by the time they have recovery of their platelet count and by the time they are discharged, when they have low ADAMTS13 still, by that time of platelet recovery, those people are at increased risk of relapse compared to those who normalize their ADAMTS13 by the time of discharge. And we know that these relapses occur more frequently in the first year or so. And as we move away from the initial episode, they tend to occur less frequently. And in terms of other factors, I don't think we have a good understanding of or a way to reliably predict who is going to have a relapse at this time.
One of a few things that came out for some older studies, like Dr. Gangaraju said, relapses tend to be more common in the first year or two after diagnosis and perhaps less common after that, although they can occur at any time. Some other studies suggested that younger patients were more likely to relapse. But really in practice, what is most useful sometimes for an individual patient is their own history. Because if someone has relapsed once, I think the chance of them relapsing a second or third time is higher. And then beyond that, like Dr. Gangaraju was saying, we've got the ADAMTS13 monitoring that is perhaps the best we have right now, but is still not perfect in predicting who's going to relapse.
I agree.
Right, and in some other autoimmune disorders, it appears that people who have underlying immune conditions like lupus may be more likely to have a relapsing or a more difficult course. And that is likely because they have underlying immune derangements that are more complicated than someone who doesn't have these disorders. That hasn't explicitly been studied in TTP, but in another immune blood disorder called ITP, it does seem to be the case.
Yep, I think you guys hit it right in the head. I mean, certainly if one patient's ADAMTS13 activity is less than 20 and another one is well over 50, the risk of relapse is going to be higher in the patient with the lower ADAMTS13 activity. But that risk is not absolute. And there are other factors which cause some patients not to relapse despite low activity and some to relapse. So that's sort of the gaps in the knowledge that we're trying to fill in with some of this collaborative research that we're all doing together.
So just an important highlight there is that a low ADAMTS13 alone does not mean a relapse is inevitable.
Correct. The risk is increased, but it doesn't mean it's absolutely going to happen.
Yeah.
Okay.
Yeah, and as we have discussed, it's not the perfect marker. I have had patients who had low Adam TS13 in the range of 30s for almost a year. And it's always intimidating to, I guess, like tell that to patients, because it's scary and it's anxiety provoking, because they know that maybe they're going to have a relapse like in a month or two, but sometimes it just stays there. And I have also had patients who had spontaneously, I guess, like normalized their Adam TS13 after being low for almost a year. Suddenly their Adam TS13 is normal. So I guess like it's one of the best markers we have, but it's not a perfect marker.
Okay, and here's another relevant topic nowadays. When is a patient who has gotten Rituxan no longer considered immunocompromised? Now, I assume this is coming up because of the pandemic and the different restrictions or guidelines that they're giving for immunocompromised patients. When would you say that the immunocompromisation is no longer?
I guess it depends if we're going to call them immune compromised in the first place. We've certainly blunted their antibody production, but there's certainly, at least in TTP patients, I don't believe there's been any studies that suggest a marked increased risk of infections. If you want to say in general, people, when you clear people's B cells out, they tend to stay low for 9 to 12 months roughly, then come back. But again, I don't know if we would consider anybody, let me see if my colleagues, if Radhika or Shruti agree. I mean, I don't think we consider them markedly immune compromised necessarily.
You're exactly right. What we can say is the low antibody levels tend to recover sometime between 6 to 12 months after the last dose.
Yeah.
But a lot of the, calling people immunocompromised on rituximab, this comes from the cancer literature where people were getting rituximab along with chemotherapy and steroids, which are truly, truly very immunocompromising. So we don't tend to see the immunocompromised patient type of infections at all in patients with TTP. It really is a lab marker of having low antibodies or low B cells.
Yeah, I agree that, I guess like I haven't had any patient with immune related infectious complications that I treated for TTP, and most of the concern comes from rheumatology patients who get Rituxan for the same reason as TTP patients, because they have immune derangements. And often rheumatologists monitor their specific blood cells to see their level of immunocompromise, but we don't do that in TTP patients. And the response to Rituxan is variable, as well as the side effects of Rituxan tend to be variable as well. So some people develop low blood counts with Rituxan, and we see that very often in people who have chronic leukemia, and they tend to have low blood counts for like 1 year or 2 years after Rituxan sometimes. And whereas others don't develop these side effects.
Here's kind of an interesting question. There's a patient who has had chronic low platelets since January 2018. It doesn't look like there was an official TTP diagnosis because they haven't been able to get their Adams TS13 tested. They use a cell analyzer to test their own platelets, and they've been able to keep that data since 2018. They normally stay around 40,000. The highest they've been at is 67, lowest is 27. And they wanted to know, their doctor, Dr. Lloyd Bass, I believe, wants to ask if there is a direct correlation between fibrosis of the liver and low platelets. They tested the spleen and there wasn't anything wrong there.
That's getting a little bit away from the TTP field, but
Yeah.
there are a lot of possible explanations for low platelet count. And I think what the person asking the question was alluding to, there is certainly liver disease where you get an enlargement of your spleen, and it looks like you've got a low platelet count because your platelets are being held in your spleen. We call it splenic sequestration. There can also be in liver disease a decreased production of something called TPO that boosts your platelet production. That can lead to a low platelet count. So it's hard to answer that question because there's a lot of possibilities. But liver disease can give you a low platelet count, not having TTP, ITP, or anything else like that.
Okay. Just to follow up on the rituximab question from before, is immunocompromised. So a patient that has TTP and has received Rituxan wouldn't necessarily be considered immunocompromised. Their IgG levels are low. and that's their physician is telling them to be considered immunocompromised because of that.
I
Is that
usually
something-
don't monitor immunoglobulin levels
Yeah.
for patients that we, yeah.
For this reason, you just don't know what to do. They're supposed to go low. We
Mhm.
just don't know what to do with them other than get nervous, so we don't order them routinely. That's kind of what you want, right? We want the antibodies to go down. We can't just get rid of the ADAMTS antibodies. We'd like to do just that.
So having a low IgG is what you expect with rituximab, and theoretically you could call it compromise of one part of the immune system, but practically it does not seem to translate into being at very high risk of infections, like some other immunocompromised states. For example, people don't need preventative treatments to prevent infection after rituximab. However, on other immune compromising treatments or in other conditions that lead to immune compromise, those often become necessary.
Just a quick statement. We certainly want to help everybody we can. It's just very hard for us to directly answer a question without knowing more about you, your case, and your lab. So we certainly want to help if we can, but we're not being evasive. It's just hard to say too much, and we don't want to lead you the wrong direction by assuming things that we think we're hearing.
So here's another question. Is there a link that you guys are aware of with TTP relapse and hormonal changes? Now, this one was specifically asking about menopause, but we can bring in pregnancy as well if you guys would like.
Yeah, pregnancy can
What about
definitely,
pregnancy then?
sorry, yeah.
No, go ahead, Radhika, go ahead to take it.
Yeah, I was going to say that we know that pregnancy is one of the risk factors for TTP episodes. In fact, some of the patients present during pregnancy or immediately after delivery with TTP, but I'm not aware of any evidence suggesting that there is increased risk with menopause or like hormonal fluctuations that go with menopause.
Yeah, as Radhika said, there is a connection between relapses or first events of TTP and pregnancy. It's just never been put together completely. So we know estrogen, whether it's the endogenous produced by the woman or outside pills, can increase your body's release of von Willebrand factor. Now, whether that plays a role, we just don't know. It's always been talked about. And I've seen a patient now, it was a long time ago, whose response to her disease changed with the onset of her menstrual cycle, raising that question, but it's just hasn't been very clearly sort of detailed out as to why. It's a good question though.
How would you follow a patient who had previously had a relapse due to pregnancy and now is pregnant again? How often do you see them and what do you look for?
So I usually refer them to high-risk maternal fetal medicine. I mean, I think at least one visit with the high-risk OBGYN helps, especially if they develop any complications. So I would encourage them to see if there is any academic medical center to be followed during pregnancy, just to be safe. But other than that, monitoring of blood counts and ADAMTS13 at least once in every 3 months to start with. And when they get closer to their delivery time, I usually start with 1 month. And usually, I guess like if there is a low ADAMTS13, we may be able to pick that before the acute episode occurs by closely monitoring the labs.
To that, ideally, someone who's had TTP with or without an association with pregnancy in the past, my preference is to have a discussion with the woman about her desire to get pregnant. And if we have the opportunity and if her ADAMTS13 is running low, I have certainly treated people with rituximab prior to pregnancy to try to get that number up to minimize the risk of a relapse during pregnancy. Because if a relapse occurs during pregnancy, not only is the woman at risk, but you're at very high risk of losing the baby. I currently have 2 patients that are pregnant with TTP, and one received rituximab and responded really well to it and has been doing fine. The other one does not respond to rituximab, and we're initially checking platelet counts once a month, but she's actually getting platelet counts checked every week now, and we've already had to treat her 3 times for a low-grade TTP relapse during this pregnancy, but things are still going okay. It's extremely high risk, but I think it can be managed.
Yeah, one of our investigators, Camilla Macias, presented this at ASH about 2 years ago, and in our experience has really been the same as Marie Scully's in the UK, and that is if you have had TTP in the past and your ADAM-TS13 activity goes low during that pregnancy, there's an extremely high, nearly uniform risk of relapse, and that's we've heard Dr. Chaturvedi talking about rituximab before. It's such a high risk. We'll try to preemptively treat people. We've used rituximab actually recently during a pregnancy. Cyclosporin we've used during pregnancies. But ADAM-TS13 deficiency alone, when you're not pregnant, is sort of a discussion of the risk. If you are deficient less than 20% and you're pregnant, that risk almost starts to approach 100%, and you really have to talk about doing something to prevent relapse. That's a real complicated question, and you should get to somebody who's done it before. But it's a dangerous situation. It's a very high risk of relapse, I would tell you.
And can't emphasize enough what Dr. Gangaraju said. You absolutely need a high-risk maternal fetal medicine person following you as well.
Yeah, and we'll routinely monitor the ADAM-TS13 activity with the labs every 2 or 3 months. If it starts to decrease, we'll do it more frequently. But it's also to say there are people who've had TTP who previously had low ADAM-TS13 activity, who in future pregnancies never dropped their activity and did just fine. So it's not all doom and gloom. We do have that marker to help us. So monitoring that makes a lot of sense in pregnant women.
So here's kind of an interesting question. Have you guys found that there are indications of patients that will respond to treatment versus patients that won't? So if you have 2 patients presenting in the ED, are you able to predict which will have a tougher course of TTP, or is it really based on the individual?
It's a good question. There are certainly some patients that we know, and a lot of the work Dr. Mazeppa had presented, maybe it's been 2 years ago at ASH, looking at differences in relapse rates in patients with newly diagnosed versus relapse versus white Americans versus Black Americans. And there are differences in terms of response rates. But it's hard to know upfront, look at 2 different people and make any judgments. The treatments have not changed. There is a greater understanding now that some subsets of patients may respond not as good as others. But I don't think our research is good enough to upfront say, relapsers should be treated this way, African Americans should be treated this way, and things like that. We're not quite there yet.
Is there an age concern? Do younger patients that present with TTP have a tougher course in your guys' experience, or is it all over the board?
Well, I worry more about my older patients for that particular TTP episode. There's 2 types of outcomes. One is what's going to happen right now with this acute episode, and the second one is what happens in the long term with relapses, etc. For the episode of TTP itself, I think there's reasonably good data from the French group that suggests that older individuals may be at higher risk of bad outcomes. But that may not have to do just with age. It's also to do with the fact that older individuals tend to have other health problems as well, like their hearts and kidneys, etc., may not be in as good shape as someone who's 20 versus 80 years old.
Are you guys aware of specifically transoceanic travel being a trigger for a TTP relapse, or are there increased risks there? There's a patient who had a couple incidents of relapse, and they were almost always preceded by travel, long flights to Thailand or to India, and they haven't traveled since due to the concern.
I mean, those kind of issues have come up in the world of blood clots and venous thrombosis, where air travel, especially long air travel, is a risk. But nothing in terms of TTP that tells us that. And I understand what she's saying. If it's timed out twice for her, I understand her concern. But I would encourage her to get with a physician that can help modulate the risk, measure the ADAM-TS13 activity a couple of times a year, and help to sort of understand their disease before saying it's certainly. I don't think staying home is going to prevent a relapse. That's maybe a better way of saying it. So.
And it was actually a Caucasian male, which they were told it was statistically unusual for them to get TTP, and so that's why they they thought it may
Well,
also be.
some diseases are more common than others. I mean, this disease is more common in Black Americans and females than white males, but there's certainly plenty of white males getting TTP. So again, we talk about percentages, greater or lesser. There's no absolute here.
Really getting TTP at all, the risk is so small because it's such a rare disease.
Yeah, it's hitting the wrong lottery. It's a lottery.
It's really hitting the wrong lottery. Yeah, unfortunately.
Is there a home tool to test platelets? And is there a home tool to test Adams TS13?
Adams TS13, no. There are certainly some patients who have cell analyzers at home, like I think the patient who wrote in earlier, and we have at least 1 or 2 patients at our center. It's not something we routinely recommend, but it's certainly something that is available at, I think, fairly high cost at home.
Yeah, I have had patients who check. I mean, I think there are point of care CBC checks that they do at home, but I'm not aware of any RMTS30 monitoring.
Yeah, I've had patients do the same, and I understand why they're worried about it. But I would tell them, if your platelet count is already dropping, and that's a TTP episode, it's too late. Once it starts, you're not going to be able to prevent anything. So that's why we use the Adam TS13 3 or 4 times a year. That gives you the chance to talk about the risk and do things to prevent it. If you know your platelet count's 110,000, we're well past prevention and we're treating an acute episode. So I understand why they'd like to do it. I would spend your time and your money getting Adam TS13 testing and visiting a physician who can help talk with you about the risk and sort of monitor and modulate that risk rather than buy a Coulter counter for your kitchen, which I've seen. I've seen that before.
What would you guys, what signs would you have somebody look for early for relapse? So is it mainly just the lab work and it's specifically just the Adams TS13, or are there other signals people should be looking for? I know a few people have written in about bruising and exhaustion, gastrointestinal problems a few have written in about. So what do you guys tell your patients to look for, or is it strictly just the lab work?
Yeah, we did an interesting study a few years ago looking at what's the difference between a patient who has a history of TTP and relapses versus a newly diagnosed. And what we found is kind of what we expected, in that people who had a history of TTP will show up sooner because they're aware of the disease and they'll think about it. And it's more subtle things. It might be bruising, it might be abdominal pain, it might be nausea, it might be headache. So patients who had TTP before will show up with higher platelet counts and lower LDHs sort of early in the course of their disease than patients who have never had it before and aren't aware of it to think about it and know about it. That being said, the outcomes were the same. There wasn't a greater risk of being refractory or dying in either group. So people tend to show up earlier when they have an awareness of the disease. And it can be something as simple as abdominal pain, I think, is probably the earliest symptom we see in patients. That might signal something.
So there's a patient who wrote in and they were initially diagnosed with ITP during a pregnancy and they received IVIG treatments, and later they were diagnosed with TTP and it looks like they were given rituximab. Do you know of any negative interactions between the two? Is IVIG known to negatively impact rituximab and its effectiveness?
It's not expected to interact at all.
Sorry, what was that?
They're not expected to interact at all.
Okay.
Rituximab and IVIG in terms of each other's effectiveness.
Okay. Would you guys say it's common, or what % of patients would you say have one episode of TTP and then never relapse again?
Good question.
I don't have the exact percentage. Yeah. But we do have some patients who never relapse. I guess we monitor them closely, but there are a few who don't relapse.
I think with time and longer follow-up with patients with TTP, I think there was initially reported something like 20 to 30% relapse, and those numbers were revised to more like 30 to 50%. I'd say at least in our center, there's maybe approximately half or less than that who've never had a second episode, but also the trend towards closer monitoring and preventive treatments will be reducing that the number of people who relapse over time. Because if we catch the RMTS13 early enough and bring it up, that relapse will probably never happen.
And what is the threshold you guys use to say what is a normal RMTS13 or in a range where you aren't as concerned about relapse?
It's a good question. So we're in the habit, I think, like both Radhika's center and I think Shreya's center, of monitoring this ADAM-TS13 in remission. And we see 4 different time points every 3 months, and you sort of make assessments based on that. But there's a lot of fluctuation in this. There are certainly some patients who will just gently go down as antibodies go up, and you have time to sort of intervene with rituximab and prevent a relapse. You also have patients who may show up for their visit, have normal ADAM-TS13 activity at 70%, but then 2 weeks later, something happens that triggers that antibody production. So they go from sort of 100% to 0 very quickly. So both of those things can happen. But I think the monitoring helps every 3 months to predict the risk of relapse. It does at least allow you to intervene in the patients who maybe are sort of limping into it or sort of gradually dropping their activity. But that strategy, like most strategies in medicine, they aren't perfect. It's the best that we've got. What do you guys think? Did I get myself lost in that question?
Word enough to treat preventatively, I think we're at the 20-30% mark.
Okay.
Where you would start to do something about it.
So speaking about splenectomy, so if you have a patient who has their spleen removed, they've had multiple relapses, do you get concerned that the platelet count can go too high? There's a patient in here who is having platelet counts. It says over 100,000. I think they might mean like 1 million. And would you treat them for a platelet count that high, or would you be concerned about it? Because there's an increased risk of blood clots throughout the body.
So the spleen is a bag of blood, and it holds on to at least 1/3 of the body's platelets. So when you take that out, it's like taking out a reservoir or taking up the, backup troops. So now everything is circulating. So it is so common that it's almost universal that you see people's platelet counts go up after splenectomy. We don't treat that separately. It is an expected finding. That said, regardless of the reason for splenectomy, there appears to be a slightly higher rate of blood clots in people who've had a splenectomy versus those who've not. But we don't treat that number per se. That's really an expected finding after spleens come out. It may go down and stabilize after a period of months, but often stays higher than normal.
Yep, I think you have to think about, like Shruti said, you have to think about also why the platelet count is high. There are some blood diseases, one called essential thrombocytosis, where the platelets are not functionally normal. And a higher platelet count with that might be a problem, certainly. But a high platelet count after a splenectomy, which tends to be transient, by itself doesn't seem to be a big problem, and we don't tend to react to it.
You tend to see the platelet count rise 1 to 2, 3 days after surgery, and then kind of stabilize down at the patient's new baseline that is often close to normal after a few weeks to months when things are settling down.
It's a good question. Doctors don't like that either. We tell them don't worry about it, and they don't believe us either, so don't feel bad.
Mm-hmm.
So here's going back to the topic of ADAMS-TS13. When in a relapse would you expect to see the ADAMS-TS13 drop? Would it be right before? Would it be prior? Would you have any warning? Or as we've said before, it's not a perfect biomarker. And then is there a reason why some patients are followed very closely with their ADAMS-TS13, whereas other hematologists are not utilizing it at all?
So I guess in terms of why it is not routinely monitored, I think there might be several factors because it is not routinely available at all the medical centers. So for example, if it's available within the like university where we are working, we tend to do it more often. compared to someone who is practicing in the community where they don't see that many TTP patients. Probably they tend to monitor it less frequently, and they may go off with regular markers such as CBC and LDH, and they may not do ADAMTS13 that frequently. And in terms of like when the ADAMTS13 goes down, I think it's very highly variable. And like Dr. Cataland was previously mentioning, even though we monitor patients like at least once in every 3 to 4 months and check their ADAMTS13, with hopes of catching those patients who may otherwise develop a relapse, there may be some patients who have a normal level. When we see them for follow-up and following the clinic appointment within 2 weeks or so, they probably have a trigger like a viral infection or something that can tip them down and they can present with an acute episode. So there are several factors that go into it.
So while it may be a good indicator if preventative treatment should be utilized, it's not a great indicator on when of preventing every relapse. It won't catch everyone, but it will help catch some.
Yeah.
Right.
Yeah.
Okay.
It would function a lot better if you could check it every day, but that obviously is not something that's feasible. So you have to sort of strike a balance of trying to monitor people without sort of ruining their lives by monitoring this every day. So that's kind of the balance that we're at now. But I would say, you know, physicians who don't monitor this may not have the same understanding or experience with this. And I would applaud them. If they don't know what to do with it, it's not a good idea just to start ordering stuff, because then that can create more confusion and anxiety. So really, to be ordering it, you really want to know what you're going to do with it when you get the result back, not ask the question after you get the result back.
Okay. As far as our the consortium's recommendations for ADAMTS13 monitoring, who wants to just state and clarify that now that it's available on our consensus documents listed at ustmaconsortium.com?
That's a good plug.
Thanks.
Well, I think to generally state how we do it, and these are trying to give guidance to physicians as well as patients, how to monitor patients. There's certainly 2 time frames that we monitor people. One is in that first month after getting out of the hospital, where we're worried about what Radhika talked about earlier, these early recurrences or exacerbations, and we know they're tied to low levels of the ADAMTS13 activity. So that's a time frame where you might monitor patients weekly until they recover. As you start to get into remission, I think the best way to describe it is 3 to 6 months, where some patients will come in 3, some will come at 6, and it's a function of how far they have to travel, how easy it is to get there, and maybe how long it's been since they relapsed. So patients, I think 3 months is better than 6 months, but that may not be good for everybody in terms of their lifestyle or travel or ability to get there. So the rough guide is 3 to 6 months, but there's some leeway there for patients and physicians to talk about, in remission at least.
Okay. And will you talk about what exactly, we'll just go over the 2-hit theory again for relapse, that there's 2 elements that need to be present, the deficiency in the ADAMTS13 and then a secondary trigger. What are some of those triggers you guys have experienced? Whether it be infection or stress, or what are some things that you guys may have encountered that have triggered TTP episodes?
That's pregnancy, that, you know, if your ADAMTS13 is already low as the first risk factor or the first shoe dropping, the second shoe dropping is often something like pregnancy. We've seen severe infection. We've also seen major surgery leading to the relapse in someone who's already got that low ADAMTS13. So the first hit is already present, and now this comes in like a second hit.
Would stress, you know, whether it be family stress or work stress, would that be an increased risk factor?
Well, I think it's plausible, but it's just one of those things that's harder to study and be certain about. For example, I can be very certain that my patient is pregnant or my patient just had surgery. It's a little harder to measure the effects of stress on the body, but it's not impossible.
And just so everybody knows what we're talking about with that, I mean, this is a pretty sharp crowd, this 2-hit hypothesis. And this kind of comes from animal models, so mice, and simply put, they bred mice to not have ADAMTS13 activity, and they did not develop TTP in the lab. Something else had to trigger it, and it helped us to understand what happens in patients. And there are certainly people living their lives who have low levels of ADAMTS13 activity, but yet don't get into trouble, and maybe don't ever get into trouble. And obviously, it's very hard to study people who never come to your attention like that. So same idea of low activity and remission doesn't mean you're absolutely going to relapse. And patients who have low activity don't necessarily develop TTP. And the one way we've seen this in humans is women that are born with congenital TTP. They're born without the ADAMTS13 protease, but they might not get in trouble until their first pregnancy in their 20s or 30s. So they've had low activity their entire life. It took that second hit of being pregnant to do it. Very good question. Sharp crowd.
All right, so that brings us to the hour mark. Anyone's question that we didn't get answered, reach out to us at admin, ADMIN, at ustmaconsortium.com via email, or you're welcome to message us on Facebook. We're very responsive. I make sure to get those answered quickly. And we will send through your questions to our medical board. If you would like more information on resources or to view those consensus documents I spoke of, we have those posted on our website as well, ustmaconsortium.com. I just want to thank the physicians for joining me tonight. I think we had another successful Ask the Hematologist, and we'll shoot for another one in the next 6 weeks. And I'll post that in the same resources where you may have found this one. So thank you, everybody.
Great. Thank you, guys.
Thank you,
That's
guys.
great.
Good to be here.